This episode of PediaCast CME is brought to you by Nationwide Children's Hospital. Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. It's episode 107. We're calling this one Child Healthcare at a Crossroads. I want to welcome all of you to the program. So we have a different sort of episode for you this week, but it is an important one because we're going to closely examine the state of child health in the United States. And I think that we can all agree that on many levels, the American healthcare system is fantastic, and it is also broken in many ways. And yet we do have an opportunity to fix and improve the ways in which it is broken. But first, we have to identify the specific problems, shine a light on them, think about them, put our minds together to arrive at workable solutions. And this is particularly important as we consider the health of children and teenagers because the system for them is just as broken, if not more broken, than it is for adults, but in different ways and requiring different solutions. Well, this was the charge of the National Academy of Medicine Committee on Child Healthcare, which was tasked with evaluating the state of pediatric healthcare in the United States, identifying key challenges, opportunities for reform, and providing evidence-based recommendations for future improvements. So what did the committee find and what recommendations have they shared? Well, we are fortunate to have a member of that committee, the National Academy of Medicine Committee on Child Healthcare. He is with us today. It is Dr. Kelly Kelleher. He is the Chair for Innovation at Nationwide Children's Hospital, and he will be with us shortly to talk about child health care at a crossroads. Don't forget, after listening to this episode, you can claim free Category 1 CME credit. Really easy to do. Just head over to the show notes for this episode over at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, click on the Materials tab, and there you'll find the post-test. Pass that test, and the Category 1 credit is yours. Absolutely free. And we do offer credit not only to physicians, but also nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And it's because Nationwide Children's is jointly accredited by all of those professional organizations that we can offer credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of the episode matches your scope of practice. In this case, it's really going to apply to everyone because if you practice, you are involved in the child healthcare system. Complete details for the credit is available at PediaCastCME.org. Also, I want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement. You can find that also over at PediaCastCME.org. So let's take a quick break. We'll get Dr. Kelly Kelleher settled into the studio, and then we will be back to talk about the state of child health care in America. It's coming up right after this. Dr. Kelly Kelleher is a distinguished professor of pediatrics, psychiatry, and public health at The Ohio State University College of Medicine, and chair for innovation in pediatric practice and vice president of community health for Nationwide Children's Hospital. He's also a member of the National Academy of Medicine Committee on Child Health Care, which is tasked with evaluating the state of pediatric health care in the United States, identifying key challenges and opportunities for reform, and providing evidence-based recommendations for future improvements. He's here to discuss the work, findings, and recommendations from this committee, as we consider child health care at a crossroads. But before we jump into our topic, let's offer a warm PediaCast CME welcome to our guest, Dr. Kelly Kelleher. Thank you so much for being here today.
It's great to be here, Mike. It's good to see you again.
Yeah, good to see you as well. I think a great jumping off point is going to be just a little more details on the National Academy of Medicine and their Committee on Child Health Care. What exactly is this organization, and a little more background on the committee that you've been working with?
Yeah, I think it's wonderful to talk about that because it's such a black box when you hear National Academy of Medicine committees. And the National Academy of Medicine is actually part of the National Academy of Science, Engineering, and Medicine. It's established, I'm pretty sure, by President Abraham Lincoln as advisory to the government and to other public policy institutions and businesses. And since that time, it is nonpartisan advice and expertise provided to, in this case, sponsors from the government mostly and from the healthcare system, and really meets in a consensus finding with public evidence gathering, reports, and then summaries of the evidence that eventually yield, in this particular case, a consensus committee, which means the committee had to come to consensus on the findings and recommendations.
It is, and just in terms of the inner workings of a committee like this, does it have to be unanimous, or is there like give and take, and how aggressive does it get in the room?
It gets pretty entertaining sometimes. So, the wonderful thing about it is that the diversity of the committee allows for a lot of opinions to be expressed, and those opinions are pretty strong sometimes, and most of us going with our, some crazy ideas on our head about what we'd really want to see change. If you could do anything and wave a magic wand, what should it be? But in the end, the committee also has to review testimony, expert evidence, and actually summarize that evidence to say why they came to certain recommendations. So you can't go out on the limb. National Academy committees are not going to propose, wild change without any evidence. So that's the point. It's evidence-based.
Yeah. So you can have whatever ideas you want, but it's going to be measured against something that is definitive. So you can have opinions, but you have to be able to back those opinions up with evidence.
Right. And I think one of the things that's been really useful for the Academy over time is that the committees are evolving to include greater diversity of opinions. Even some of my early committees were almost 100% physicians. And now we're seeing, people from a wide variety of walks of life, executives, business leaders, community representatives, certain subpopulations that have been underrepresented, parents of children with chronic illness. So a wide variety of opinions. And of course, that makes for a much richer report.
Yeah, absolutely. And you have more representation of the stakeholders,
Exactly.
which is not just physicians as we consider healthcare. So then what is this committee in particular charged with accomplishing?
Right. So this committee was, as any report, sponsors are sought. Sponsors come forward and say, we are seeking answers to the following questions. And in this case, it was a wide group of sponsors focused on pediatrics because people had noted that the National Academy of Medicine put out several child reports over the past 5 years, very influential reports, Neurons to Neighborhoods, the report on SSI, Supplemental Security Income for Children. There have been 4 or 5 different reports, but really healthcare was not the central theme of any of them. They were all focused on early childhood learning or SSI or other policies, Medicaid, but not healthcare per se. And so the American Board of Pediatrics, the American Academy of Pediatrics, the Bureau of Maternal and Child Health, the Children's Hospital Association, a few foundations all stepped up and said, we really need a report to say where healthcare should be changing, because there have been several adult reports on where healthcare is going, but child healthcare have been left out of most of those.
Yeah. Now, why was this important now? It seems like this has been important for a long time, but why was this organized and brought together now, post-pandemic and in our current state of affairs?
Yeah, great question. And, those of us in the field, of course, always think now is the right time for child health care. But for the rest of the world, this year and these past couple of years have been some striking things have occurred that have really jolted the system. One is, for the first time ever, we're seeing child mortality worsening in the United States, not in the rest of the world, but in the United States in particular. And, we are on track with chronic disease, obesity, mental health problems to have the first generation of children whose health is worse than their parent. Another shocking study came out of the Defense Department noting that about 70%, somewhere they estimate as high as 77% of all young people would not be eligible for the military because of either medical, mental health, obesity, or other problems with their health. And a number of business leaders have put out warning flags that they will not have an adequate workforce to continue to grow and be productive. So, the nation is also looking to find out where are going to be the people to care for the growing number of elderly. And there aren't enough healthy children in the pipeline. So the shocking numbers just woke everybody up. Unfortunately, we should have been focused on this all along, but of course, the pediatric healthcare system has always been wagged by the tail of adult healthcare. We're just a legacy system. So we've not really designed a healthcare system, which has left to a lot of fragmentation, lack of focus on what kids really need compared to adults, et cetera.
Yeah, yeah. So, and I think it is important to note that suddenly we have a 5-alarm fire, but at least people are paying attention, and that's really the most important thing. So, as you're putting a committee like this together, you had mentioned that there's a lot of different disciplines represented, and there's a lot of diversity. Can you describe the structure of that committee just with a little bit more details?
Yes, very much so. Thanks. The committee is actually, so as I mentioned, it's an evidence gathering body, but it has 2 chairs, and we were very ably chaired by Dr. Jim Perrin, who's won the St. John Award this year at the Pediatric Academic Society meetings, and Dr. Tina Chang from Cincinnati did an outstanding job. And they chair the experts who are gathered from all across the country and pulled in by the staff. And then the committee is also staffed by full-time workers at the National Academy of Medicine who help provide background materials, organize the meetings, establish the credentials for everyone, help work on ensuring there's no conflicts of interest, and provide a lot of the writing support for our various pieces that have to be all woven together.
And then how does that committee then come together to actually develop recommendations?
It's a great question. So the committee does some initial communications about obvious sources of evidence for the questions that have been raised, such as what is the future of healthcare? What are the future financing tools? What kind of accountability will we have in the future? What new innovations are coming down the pipeline that are likely to change practice radically? Even what financing mechanisms we need to think about. So those initial background materials are brought together, and then the committee conducts a series of expert presentations. The beginning of each meeting is an open meeting for the public. Experts present their opinions, committee queries them and asks questions. And then besides their presentations, people from the public are invited to send comments and make comments on the presentations or materials that are being presented. And finally, the materials all gathered and put into books, briefing books for each meeting when we talk about various topics. And then subgroups of the committee actually proceed to sort of outline writing and on various topics, which we put together in response to the questions of the sponsors. And so not everybody writes the same, and different people play leadership in writing or not, but everybody hopefully gets opinion. The materials reviewed, each section is reviewed by the whole committee, and it's also then all put together with the help of the staff, and then it gets sent out to an independent set of reviewers. I believe there were 18 reviewers who donated their time to review the whole thing and make comments on the various components. And then revisions are done in response to those comments. And then finally, the committee agrees to sign off on it once those 2 steps are complete.
Yeah, yeah. And there's really 3 sort of stages in this as you're writing it. You have the findings, but then as you take all of those data points, then you come up with a conclusion based on all of that data. And then the piece that I'm really interested in is going from the conclusions to actual recommendations. How does that happen?
Yes. Well, with great, great intensity, usually. So,
I'll bet.
so obviously, when you're talking about all of child healthcare, it's a voluminous topic, and our report is long. It's 600 pages, but the recommendations really are very, supposed to be very few in number. And so, what we do is that when you study all of child healthcare, there could be thousands of findings, things that we actually see in the literature that are pretty clear, and we say this is a finding. Well, when you bring a bunch of findings together, you might conclusions that we have, there's a trend toward private equity in healthcare, and we need to talk about that, or AI will radically alter the practice of healthcare for children in the future, and here's some, conclusion about it. It needs to be equitable. It needs to be this. It needs to be that. Then our recommendations would be what to do. And they have to be recommendations, take a next level step and say, who's the target audience, has to be specific. What's the specific action you're requesting of them? And what's the time frame for it? So it also has to pass the everybody agrees test. So based on the evidence and
Yeah.
conclusion.
Yeah, absolutely. Well, let's actually dive into some of the findings. And where are we in terms of the U.S. healthcare system and our performance for children? Where exactly are we right now?
Well, no surprise, to anybody, I don't think. But, the healthcare system provides some of the world's most sophisticated care for specialty conditions on the planet. No doubt about it. And many of the great discoveries still happening in pediatric healthcare are happening in the United States because of the unbelievable research that's being done in healthcare in the United States. We also see amazing innovations happening right now. And I mentioned a couple, but all the uses of exome and genome testing and neonates and things that are coming down the pipeline, seeing the amazing uses that people are applying for all the new technology, digital tools for families and engagement, but also digital tools in clinician decision and system decision making. So those are all moving along amazingly fast and certainly are going to affect our practice within the next few years. There are longer term things as well, data interoperability, innovations, things that will happen in the cloud that, I think we'll see fairly soon.
Yeah. And what are some of those major shifts that you think are on the horizon?
Well, I think for example, we expect that team-based care will be facilitated greatly by a lot of the technology that's coming along. As people are better able to practice at the top of their license so that medical assistants, nurses, nurse practitioners, physicians, they'll work more effectively as teams to care for whole panels of patients and groups of patients across sites and more flexibly. We won't be so site bound. We won't be so office bound and working with patients more continuously in relationship rather than visit based. So moving from a visit based system to a person centered system and a family centered system will really help children, especially.
Yeah. I would think that there's a big role then for telehealth as a part of that.
Absolutely. Telehealth is going to be central for a lot of families. It's also central for a lot of providers and clinicians who find themselves very isolated and needing, Project Echo and other things that reach out to clinicians is great for education, but we need more and more real time, more and more both synchronous and asynchronous. So, and there'll be a need for more podcasts for education, Mike. So you're going to be more in demand.
Yes, yes. That is good news.
Right.
Now, in terms of there's the actual function of providing healthcare, but then that healthcare also has to be paid for. Are there challenges in getting a new sort of framework actually paid? Because it would seem that the visit model is how we are reimbursed.
Absolutely. Absolutely. So the challenges are large for change. I think some of the rapid transitions in our environment that are happening right now in Washington and at the State House and in other places around the country are precipitating new thoughts about that. And people, with every challenge comes opportunity. So I think we may see some transitions more quickly than we think. But there's already several models out there that don't rely on visit-based models and have shown some pretty good outcomes, some innovations. more importantly, there's an agreement that population health outcomes, the ability to include all patients in your accountability, is a way to be paid much more sustainably. So what I mean by that is right now, everybody can say, oh, my patients are very satisfied and they all got good care, but that's just the ones that showed up. We know a lot of patients either aren't coming, aren't able to access, or have trouble accessing care. And a large proportion, for example, somewhere between 40 and 50% of adolescents don't get routine care. As just a simple example, it's true at every other age, but it's very particularly true for adolescents in our system. And many communities feel disenfranchised. If we were to require population level metrics where outcomes were determined based on the entire population rather than just who showed up, I think it would change how we focus our attention.
Yeah, absolutely. You've talked about the privatization of particular parts of the healthcare system. And then there's also, especially in kids whose families are in a financial position that they're not able to afford privatized healthcare, there's a whole public healthcare system kind of in parallel. What role can a partnership between the private ventures and the public ventures, come together to help the whole system?
Well, I think there's two aspects to that, your question, and I'd love to talk about it a lot more, but there's the aspects of public and private healthcare, how those systems work together. And then there are aspects of public and private entities within a community that can come together to improve child health. And so the first a good example is our own, and it featured in the report, is our own Partners for Kids accountable care organization for children. And in the ACO, we have private pediatric practices that are networked with community health centers and academic medical centers to all provide care to a population of 500,000, not quite, but 500,000 Medicaid children, enrolled children. So, coordination across those systems, the ability to coordinate, for example, behavioral health delivery in primary care settings, regardless of the settings or because of the settings, and modifying it in each type of setting for the particular patients, that's an example of public-private collaboration and data sharing that can go a long way.
Yeah.
On the other side, we have community agencies. We have public and private entities in the community that can come together to actually improve the health outcomes for kids. And we do that by, for example, when, the Columbus Partnership works with the mayor's office and works with Nationwide Children's Hospital and the public health department to all come together and work on infant mortality in the Celebrate One initiative. And, sometimes it's donating money, sometimes it's donating data, sometimes it's communications to all your employees in the private system. And they come together around what we call Celebrate One, which is an infant mortality prevention initiative locally. So child health is not a healthcare sport. It's really a community sport, and everybody needs to be involved. And we should stop talking about it as if we can fix it in the doctor's office, because we can't.
It seems that one thing you really have to have is a person or a panel of people who are sort of in charge of bringing public and private resources together, because it's not going to happen on its own. And if you rely on the clinicians to do it, like, they're so busy, how do you do this? And so it would seem that recruitment at the community level of someone who can organize such a thing is going to be an important part of making it happen.
I think what we've learned is that the communities that have done the best job of improving child health outcomes and initiatives to do so do have what's called a backbone organization. They have someone who, in an organization that is providing the meeting place, the gathering, the staffing, the data management, the quality improvement, the outreach. And, in Columbus, we're fortunate that the hospital is very involved in doing so. Cincinnati Children's has done the same. But in other places, it may be the public health department. So in Minnesota, we had some examples presented there. In Oregon, there was actually some models where the managed care companies were taking some leadership role. So it's community dependent. And I think that's what's complicated in some part with recommendations, is no one solution will fit every city in the country.
Yeah, that makes sense. One thing that we hear about is Medicaid reform. That's just kind of a buzzword that you hear in the news even. What exactly, or how does Medicaid need reformed?
Well, Medicaid pays for half of all childbirths in the United States right now and takes care of almost half of young children. It is the payer for 40 to 45% of all children in the United States, and the majority of those with severe and disabling conditions. So Medicaid is the along with CHIP, the supplemental program that was passed years ago to join that for kids who are not quite as low income. These programs are the safety net for most children. And right now we have a lot of good evidence on what works, and we're not implementing it. What works, we know, is, for example, continuity of enrollment. When children are disenrolled frequently, they miss preventive care. When children are disenrolled frequently, they lose medication continuity and they lose specialist continuity. So we know that routine enrollment, we know that facilitating enrollment, we lost many eligible children to Medicaid during the recent unwinding of the public health emergency after COVID, when many people were disenrolled, but many of them were still eligible. They just didn't know it or didn't understand the process of re-enrolling. So many children became uninsured. And then similarly, we know that the benefit coordination needs to be there. Medicaid is a great laboratory for improving outcomes for the entire population. And Ohio, Oregon, and Virginia, a couple other places are taking some innovative steps to do that.
Yeah. And I would imagine that too, those steps are going to be very specific for individual states, individual communities. And as you said before, what works in one place may not work well in another. And there's not necessarily one size fits all.
Well, we do have some pretty good data on things that do and don't work. For example, I think in the report we talk about, work requirements for parents haven't been very successful for the most part. We know that continuous enrollment has been successful, especially successful in improving maternal outcomes too in the early years right after delivery. We know that making sure that children have coordinated behavioral health services is very important. So we do have a lot of research out there that what works, but I agree with you. Local adaptations to fit within the context of existing, healthcare organization matters.
Yeah, absolutely. What is the role of pay for performance in pediatric care? I think that's another one of those buzzwords that we've heard recently.
Yes.
What is that exactly?
Yes. So great excitement originally about what was called pay for performance and equity bonds. Can we pay people enough to have good outcomes? And the idea here is, for example, if you pay obstetrical services well enough and for successful outcomes, reducing infant and maternal mortality, then, that would make them provide better care, do better outreach, include more accessibility, be more attentive to people. We do think that pay for performance works in some situations for adults because there are some expensive outcomes. Transplants, for example, if to pay people for successful transplant maintenance. Transplant teams follow up patients more effectively, include more diverse representatives. So the idea here is paying for an outcome. Pediatrics is particularly challenging in that regard because we don't have enough high cost, expensive cases that are predictable, and somebody, by changing medical care, could do it. We do have plenty of situations where we could change housing or the education system or other things and improve outcomes, but not classic medical care improvements. So pay for performance traditionally doesn't work, but there's some new pilots out there that are trying to wrap together healthcare outcomes, educational outcomes, child welfare outcomes, and say, could we do pay for performance in a community to improve the well-being of children?
Yeah. It would seem that there's some factors outside of the system's control that also impact outcomes. So it's not necessarily always the medical team, I guess you'd say, at fault, but there's all sorts of issues at play. And I would imagine from the provider standpoint, sort of being penalized for poor outcomes that might not really be your fault might not sound fair.
We certainly heard that from the clinicians. Clinicians did not want to be held liable for things they, quote, could not control. But, when we've used that argument for a long, long time to hide in our offices and not go out to patients, not include community health workers, not include family issues on transportation. We said, oh, the patient was non-compliant, or they didn't show up, they were a no-show, or they didn't follow my orders. Not considering whether our system and our services were the best provided. Moreover, when we say that the medical system doesn't control it, well, the medical system is 22% of the U.S. economy. If we can't control things or figure out ways to improve things, then who can? So I think there's a balance here we have to find, and I think the balance is that when possible, and some of the state Medicaid agencies are beginning to get close to that, of saying not all outcomes should be paid for performance, and certainly not all conditions, but the healthcare system has to do a better job of considering social factors.
And along with that, so the two things that we've really talked about here, sort of the reform of the system, and if you're going to have pay for performance, like those have to evolve together, because without that change in the system, you're not really going to be able to do as good of a job of having great performance.
That's right. And, the interesting thing for me was the exciting number of innovations that were occurring all around the country. Lots of people are states are experimenting with new ways to pay. So, for example, California and Delaware were doing innovations in maternal infant dyad payments to try to get good care for both. And Ohio and Oregon were trying to incentivize the managed care organizations to do more prevention care by doing a quality withhold that was very focused and very intensive compared to the traditional low-level incentives. There are other places doing some experiments with team-based care and reimbursing differently on that. So again, some places are doing it, but they're doing it in pockets. And how do we make it scalable and disseminable? And how do we teach other sites how to embrace some of these things?
It would seem one way to do that is the public health system, just because every community has one. And, because it's a government-run office, that there could be some coordination amongst public health agencies across the entire country. Is that sort of network being utilized to try to create this change?
Yeah, that's a great call out. And in fact, the best public health agencies we saw and heard from around the country were ones that were partnering with the healthcare instruments around them. They were partnering with primary care, they were partnering with hospitals. And in those places, for example, a couple of cases, child vaccination rates were increased. And, you saw that there were lower prevalence of food insecurity. So we know that public health is probably the right place to coordinate with healthcare, whether, who should be in charge, who should drive things. I mean, all those things could be negotiated, but it's clear that the combination of healthcare and public health data together tells us a lot more about how children are doing in a community and areas where we might need to intervene.
Yeah. What's the significance then of school-based health programs? Because that's another thing that has some government control. It's a place that most kids touch during, a typical day. So it seems like if we're really interested in them not falling through the cracks, meeting them at school may be a good idea. And I know we have a pretty advanced school-based health system here in Columbus, but how does that look across the country?
It's hit and miss. School-based health systems are occasionally threatening to the local pediatricians who say, I don't want, my patients to go there. I want them to come here for their shots and other things. And that's fine. The best school-based health systems actually coordinate with local clinicians. And so, and I know we do that here because, checking with the local community, asking each student at the school before they get care, who's your pediatrician or your clinician. So I think coordinating with local primary care is key. But having said that, there are innovations in both state funding. So there's been some really innovative state funding in some states. And in other states, the FQHCs, for example, can get very high levels of reimbursement for wraparound services, both behavioral health and primary care in schools. And so some of them have taken huge advantage of that around the country. And so I think it's critical, especially because we're missing certain groups of people who do not access the routine primary care system. So schools plus our primary care system may be able to coordinate and reach all those kids. But again, This is a place where if we don't share data and information, so, I mentioned public health and the connection with primary care. Well, now schools and primary care have to do the same.
Yeah. Yeah. What is a peer-led model of care?
Yeah, this is, we are experiencing some major shortages of primary care services across the country. And speaking of the National Academy, their recent report on primary care really, paints a picture of a system and it's being disrupted right now and is suffering because of both lack of investment in some places and then certain kinds of investment that actually reduce the number of clinicians in others. So in response, what we've tried to really see is that how are we going to extend and complement systems, services that are out there? And the peer systems are either adult peer-to-peer, so family members coming in and helping family members of other children in the healthcare system, either teaching them, for example, how to work through the IEP process for their kids to go to school, or, oh, I had a kid who was in the crisis unit as well at a psych hospital, and here's things that are going to come up for you once they leave, and what do you need to think about, and here's a family management plan. So adult peer models are peer-to-peer, and then there are also near-peer models, which are recent adolescents, so college-age kids who do certification and training to help adolescents then and work on things like, for example, developing a no one eats alone in the cafeteria club at high school, or work on societal anxiety and depression that occurs in schools. So we have different kinds of peer models, and those peer models are getting certified by states like New York. They have a formal certification program under the Department of Nursing and getting paid for through Medicaid. So again, we need to extend the model. We need to substitute for some clinicians where there's simple interventions, but it's an emerging field, but the evidence so far is pretty strong.
Because at the end of the day, we're interested in health outcomes. I mean, we want kids to be healthy. We want them to live longer. We want them to be able to serve in the military. We want them to be able to join the workforce, all those things. And how you get there, traditionally it's been you go see a physician. But as our population grows and we aren't keeping up, especially in primary care, with being able to provide those physicians, we have to find alternatives because we are interested in the outcomes. And so that may mean some models in certain areas that are very different than what we're used to. And of course, there's always going to be some pushback when that happens. However, if we keep our eye on the fact it's the outcomes that matter, then we can sort of justify these, non-traditional forms of providing care.
I think that's right. Exactly. You stated it much more clearly than I did. But the challenge is in these discussions is that although most of us who are clinicians are in the room saying exactly what you just did, that we really want the child to be better here, for many of the non-clinician players in the room, this is a business. And, to some extent, we're threatening the business by adding low-cost, non-healthcare interventions. And so, for example, in behavioral health, we have clear evidence that exercise matches or exceeds the value of antidepressants in treatment of early anxiety and depression. And yet it's hard to get exercise paid for, exercise programs paid for, but you can get drugs paid for. And again, there are very powerful influences that, have to participate in these discussions to change things.
Yeah. Yeah. How then do you take a capitalist society who is, very fond of a private healthcare system and not, one size fits all like we see in Canada and the United Kingdom? How do you still let there be financial incentives so that it can grow within our current system?
Well, I think the number one is we have to be smarter about the incentives, and rather than making the incentives all about the trying to get private pay patients into exclusive settings and, all competing for that. If we make the incentives about population health outcomes, then we have a chance because now we're talking about the entire population being served. Another big thing that we have to do is agree that there's going to be that the business community has to come together and agree that this is important. And we actually had members of the business community here in Columbus testify before the committee saying how this was important for their future workforce planning. And we have to have healthier children. And they think it's important enough to try to influence the system. So they were willing to participate in solutions. And that's the kind of, if we get the business community on board and we have political representation on board and we engage communities that have been disenfranchised for a long time, I think we might have a coalition of the interested to make some serious change.
Yeah. So you really do have to get public and private working together on this, and not only in the healthcare system, but in private business and in, just government in general.
Absolutely.
And you have to have champions at each of those levels as well.
Yeah. And we've been blessed here in Columbus to have that, locally. And now how to figure that out. I mean, we have to do more, obviously, but we've had real champions in the business community step up and say, no, this is important. We need to do more affordable housing for kids. And we need to do more, parent hiring in neighborhoods that are affected. And we need to do more to prevent violence in the community. So I've seen it happen with large corporations. We just need to make sure it happens more universally.
Yeah. And then that speaks really toward population health. Just one last thing. What exactly is population health, and how does this impact where we are in terms of providing healthcare to children?
Yes, I've mentioned that a couple of times. So, traditionally, healthcare was about thinking about my patients, me as a pediatrician seeing patients, and they're my patients, and how am I doing, and getting paid that way and accountable that way. Then it became, how's my practice doing? And then it was, how's my health system doing? And then it's, how's the insured population? We've realized that each of those is too narrow a view, and we have to have some metrics. And in fact, the National Academy of Medicine started publishing in 2015 about the need to have community-level indicators of accountability for healthcare systems, that we need to be able to say across the entire community, my patients or not, at least some of our metrics have to be how well this system is performing. And it involves two measures. First, the mean or median health of the children in our community, and you can measure that in a variety of ways. But then also how much inequity there is, which groups are being left out or which are most vulnerable. So those are the two aspects of population health that when we think about from that perspective, then number one, we're ensuring that all the children are included. And number two, we have growing evidence that the fewer disparities and inequities there are, the more healthy all the children are.
And one area in particular that comes to mind as we think about this is infant mortality rates. And oftentimes those do affect certain populations more than others. And so when you do take a look at population health and you're looking at the big picture, then those disparities really start to become glaring, and then you can come up with solutions once you've identified those issues.
Yeah, absolutely. We have several areas where we're improving outcomes, and you think about things like waterborne illnesses and things like that in this country, or our response to some of the emerging zoonoses. But for infant mortality, a classic example, we've shown a steady decline in infant mortality, although it's paused a little bit across the country, but there's still a 2 to 3-fold increase for certain subpopulations, depending on where you live. And it's 2 in some places, 2 times as high, and it's 3 to 4 times as high in others. So it's shocking when you tell people. Most people don't believe it, but if you look at the numbers, it's really clear.
Well, this has been a very interesting conversation, and it will be even more interesting to sort of journey forward and see where this all goes, because hopefully it's going to make a difference. That's what we need.
It'll be a wild ride, Mike.
Yes, absolutely. So, Dr. Kelly Kelleher, thank you so much for being here today. We do have some show notes. We do have some great links in the show notes this week. Number one is an article from the National Academies of Sciences, Engineering, and Medicine called Improving the Health and Well-Being of Children and Youth Through Healthcare System Transformation. And another one, the new report provides roadmap for policy changes to transform child health care and meet the challenges of the youth health crisis. That is an article also from the National Academy of Sciences, Engineering, and Medicine. We'll put links to both of those in the show notes for those who want to dive in a little bit deeper. But once again, Dr. Kelly Kelleher, Chair for Innovation in Pediatric Practice at Nationwide Children's Hospital, thank you so much for stopping by today.
It was great, Mike. Thank you.
are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. We really do appreciate that. Also, thanks again to our guest this week, Dr. Kelly Kelleher, Chair for Innovation in Pediatric Practice at Nationwide Children's Hospital. Don't forget, you can find PediaCast CME wherever you get your podcasts. We are in the Apple Podcast app, Spotify, iHeartRadio, Amazon Music, Audible, YouTube, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with show notes for each of the episodes, CME information, our terms of use agreement, and that handy contact page if you have a comment or would like to suggest a future topic for the program. Also, reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Instagram, Threads, LinkedIn, Twitter, X, whatever you want to call it, and Blue Sky. Simply search for PediaCast. So you have listened to the podcast. Now be sure to claim your free Category 1 Continuing Medical Education credit. Really easy to do. Just head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, click on the Materials tab, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we do offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you want to be sure the content of this episode matches your scope of practice, which it most likely does. Complete details are available at PediaCastCME.org. Also, don't forget about PediaCast. It's our evidence-based podcast for moms and dads. Lots of pediatricians and other medical providers also tune in as we cover pediatric news, answer listener questions, interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Another thing you might want to share with your patients, if you look up PediaCast on YouTube, we have begun a new video education series. They're really short videos on important topics for parents as they think about child health. So things like fever, for example. We talk about the recent measles outbreak and the MMR vaccine. We've talked about eczema. And again, they're short, 2 to 4 minute kind of things that may be helpful as educational materials for your patients. So please do share PediaCast with your practice, and that's a new resource over on YouTube. We also have a faculty development podcast. So if you are practicing in academic medicine, this is from the Center for Faculty Advancement, Mentoring, and Engagement at The Ohio State University College of Medicine. It's called FameCast, and the landing site for that program is famecast.org. Also available wherever podcasts are found. Just search for FameCast. And again, that is a faculty development podcast from the Ohio State University College of Medicine. Thanks again for stopping by. And until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.